In orthopedic oncology, the objective is a brutal calculation. The surgeon must completely eradicate a deadly tumor while preserving the patient's functional limb. For extremity soft tissue sarcomas, the primary treatment is surgical resection. Success is measured by achieving negative margins, ensuring no microscopic cancer cells remain at the edge of the removed tissue. The surgeon relies on the radiologist to provide the literal three-dimensional coordinates for the scalpel. These coordinates transform a diagnostic scan into a high-stakes tactical guide. This diagram outlines 4 surgical excision boundaries. A radical excision, the red line, removes the entire anatomical compartment. A wide excision, the yellow line, cuts healthy tissue away from the tumor's pseudocapsule. The green line, a marginal excision, passes directly through it. Finally, the purple intralesional line violates the tumor. The surgeon cannot see microscopic spread in the operating room. They rely on the specific grayscale signal intensities on an MRI to determine which of these 4 lines to follow. Every MRI report acts as a prescriptive life or death map. These findings directly determine whether a patient's limb survives the operating table. Drawing that map begins with identifying the anatomic compartment. These are sections of the limb bounded by natural, dense barriers like fascia or bone. This axial MRI maps the distinct compartments of the extremities. You can see how natural boundaries isolate zones like the anterior and posterior sections of the thigh and leg. These barriers establish a fundamental rule of sarcoma margins. The type of tissue matters more than the physical distance from the mass. A single millimeter of intact fascia offers a stronger defense against migrating cancer cells than several centimeters of normal muscle or fat. This MRI shows an intracompartmental tumor. The mass remains entirely contained within the outlined boundary of the anterior compartment. By contrast, this extracompartmental tumor has broken through the boundaries, spilling across multiple zones. Crossing a compartment line changes the surgical scope. A wide excision must often escalate into a radical resection of multiple muscle groups, necessitating massive reconstructions to close the tissue defect. Defining the compartment boundary sets the macroscopic limit for the blade. This prevents a localized procedure from escalating into an amputation. Radiologists zoom in from these macro compartments to the micro interfaces. The interaction between the tumor and the fascial barrier is the first priority. This coronal MRI displays a mass actively breaking through the fascial plane. The scan must be scrutinized for any millimeter-scale breach. These perforations force the surgeon to abandon a close margin, instead resecting a wide path of healthy tissue to clear microscopic spread. True bone invasion is uncommon, occurring in only 5 to 12% of cases. However, the bone represents the ultimate rigid anatomical barrier. Physical contact between a tumor and the bone does not mean the bone is infected with cancer. This is a critical distinction for surgical planning. Here, a massive tumor presses directly against the dark ring of the femoral cortex. The protective fat plane has been entirely obliterated. Despite this aggressive contact, the marrow and the dark cortical line remain pristine. The internal signal of the bone is unchanged. Because the bone is not invaded, the surgeon can strip the outer periosteum. Periosteum is the dense fibrous membrane covering the surface of bones. This technique saves the femur and avoids a devastating skeletal resection. Identifying the difference between abutment and true invasion saves vital structural tissue that might otherwise be amputated. The proximity of the tumor to the primary neurovascular bundle is the most high-stakes relationship in the limb. Involvement of major nerves and blood vessels is the ultimate factor in determining if a limb can be saved. This MRI shows a tumor displacing the neurovascular bundle. Notice the arrowhead. A sliver of white fat remains between the mass and vessels. This intact plane allows for neurolysis, peeling the tumor off the nerve's outer sheath to achieve negative margins and preserve function. When that fat plane disappears, radiologists apply strict mathematical rules to circumference. This begins with the 180-degree rule. Contact of less than 180 degrees is considered abutment, allowing the surgeon to dissect the tumor free from the vessel. Contact exceeding 180 degrees is true encasement, increasing surgical risk. The point of no return is 270 degrees of contact. Here, the structure cannot be freed without violating the tumor capsule and spilling cancer cells into the wound. Crossing 270 degrees usually means major nerves must be sacrificed or complex arterial bypass grafts must be built. This measurement, calculated in degrees of circumference, dictates whether a patient wakes up with full use of their hand or foot. Clinical practice often assumes a needle biopsy is the final word on a tumor's grade. Sarcomas are highly heterogeneous, with different areas behaving differently. A needle might extract falsely low-grade cells while entirely missing an aggressive core, a phenomenon known as sampling error. The radiologist uses the full volume data of the MRI to correct and overrule these misleading pathology reports. In this case, the initial biopsy suggested a low-grade sarcoma. The MRI reveals a massive lesion with a chaotic, necrotic center. Necrosis is the premature death of cells in living tissue, typically indicating a high-grade malignancy that the needle simply missed. Trusting that biopsy over the MRI would lead to an inadequate resection and almost certain local recurrence. The radiologist also looks outward from the mass to identify abnormalities in the surrounding tissue. They must distinguish between feathery reactive edema and the dangerous phenomenon of peritumoral enhancement. Thick, enhancing fascial tails represent invasive microscopic disease, physically creeping away from the primary tumor mass. The surgeon must radically alter their physical trajectory to envelop these invisible tails to achieve a true negative margin. These imaging findings all culminate in the original surgical roadmap: compartment lines, fascial breaches, vessel encasement, and enhancing tails locked together to dictate which colored line the surgeon is permitted to cut. The MRI functions as a live surgical instrument. Its interpretation serves as the absolute threshold between oncologic eradication and preserving the patient's quality of life.